Hello? Hello, can you hear me? Hello? Good afternoon, Dr. Bashar. Can you hear me? Because I can't hear you. Hello, there we are. Very well indeed, thank you.
Thank you. Thank you very much for your participation.
Yes, I can hear you very well now.
Okay, thank you very much for your support. Thank you.
Always a pleasure and an honor, Dr. Bashar.
Thank you very much. Thank you. Very kind of you. Thank you very much.
Just let me know where I can when I can introduce it, and then no problem.
Yeah. Everybody here in this conversation? Can start now if you want.
Okay. Good afternoon, everybody, or good evening. It depends where you are. And welcome to this webinar on the transconjunctival blepharoplasty. This is actually a very trend topic because transconjunctival blepharoplasty actually started in mid-90s and became more and more popular, avoiding the traditional blepharoplasty incision. So, because of this, avoiding the external incision gives the advantage of avoiding complications like scleral show or ectropion. But who is the ideal candidate for this kind of a procedure? And which are the key maneuvers for a successful operation? Dr. Bizrah has a great experience on transconjunctival blepharoplasty. So, let's hear from him all the right tips and advices. Thank you, Dr. Bizrah. Anytime you want to start, go ahead.
Okay, thank you very much, Mario, for your nice introduction. Welcome, everybody, for our webinar number 26. Today, we are going to talk about transconjunctival approach blepharoplasty. As Mario said, it started actually in the mid-90s. Actually, in 1995, I personally went to Chicago to a famous surgeon called Antonio Giroles, where I observed him doing this transconjunctival approach blepharoplasty. I learned from him, and then I returned back to my home country and I started doing the transconjunctival blepharoplasty. So I've been doing actually this for the last 29 years. So since 1995, I started doing the transconjunctival approach blepharoplasty. We have a huge experience. We have done thousands of cases. So the technique really is a super technique. It leaves no scar, and it's the technique of choice for younger patient and mainly patient who have really many buffiness and fullness, and eye bags, and bags in the eyelid. So we are going to cover now some theory, very important theory to very important subject. Of course, this is just a very important facts about plastic surgery in general and about surgery in general, that there is no perfect healing process, no perfect surgical result, and the master may even slip sometimes. So therefore, near respectful surgeon would guarantee results. You have to keep this always in your brain and between your eyes. These facts are very important for every surgeon. Now, what really, before we start talking about the approach, what really is the eye bag's effect on the person? How does it affect the patient? What's the patient when he comes to you to the clinic? What is really main complaint? Usually, patient complain that he always looks, got the fatigue appearance, or he looks older than his age, or the anxiety appearance, or he looks as if he's stressed. Always, for example, his colleagues at work in the morning tell him, "What's wrong with you? Why are you unhappy? What happened?" He looks anxious, depressed, stressed, or he got a sleeping appearance. If he, it looks if he did not sleep well the night before, and also that causes some, lower self-esteem in the patient. And also, always patient with buffy eye, they have this social perception. They may get less attention from other people because they think he's either sleepy or stressed or depressed, so they don't really to have a nice communication with such person. And sometimes the buffiness under the eye may cause, if it has severe buffiness, it may cause some stretching of the skin and cause tenderness or itching. and some discomfort. Also, some people complain because of the light shadow. They complain of darkness in the lower eyelid. So that's really the 10 most common complaint of the patient when they come in the clinic to see you, about the eye bags and the eye puffiness. What really is the main indication for the transconjunctival approach? What the superiority of the transconjunctival approach on the open approach? Why we go for transconjunctival approach and not for open approach? So the transconjunctival approach is when you have really the lower eyelid fullness, puffiness, and bags. It's mainly suitable for younger patients. Some patients from the age of 20, they have this eye puffiness due to some genetic factors. So that's very important that really you have to choose the right patient for the procedure. And the patient should understand that this is not going to lift his skin, not going to stretch his skin. It's only to treat the puffiness, only to treat the fullness in the lower eyelid. So what really is the causes of lower eyelid fullness and the eye bags and the puffiness? What are the more common causes? And we say genetics, hereditary. So we have done many patients at the age of 20, 22, 25, between the age of 20 and 40. This is caused usually by hereditary. They always say my mother, my father, my grandmother, my grandfather had the same problem. And then the second cause is the aging process. Patients above the age usually of 40 may have puffiness due to the muscle laxity and fat herniation. Again, lifestyle may affect really the under the eye, lower eyelid, and causes the puffiness and the fullness, like smoking, some exposure, lack of sleep, as we just said, and some people who consume a lot of salt. For example, people who eat a lot of nuts, mainly at night. And again, stress, crying, allergic reaction, alcoholism, and thyroid disease like Graves' disease may cause the puffiness and anxiety. Therefore, you have to exclude the Graves' disease when you suspect this in some patient. What's the contraindication for transconjunctival approach? What's the contraindication for lower blepharoplasty transconjunctival? Patients who are not going to benefit from the approach, when patient has, of course, excess skin. We said at the beginning, patient has excess skin there, a lot of lines, a lot of folds. The patient is not going to have really much benefit from the procedure, should understand this. Therefore, the patient should really sign a very comprehensive, informed consent to explain what's really the purpose and the aim of the procedure and how the procedure is going to help the patient. That the aim of the procedure is only to treat the fullness and the puffiness. You have to be very careful not to confuse between the eye bags, lower eyelid bags, and the malar bags, the festoons, the malar pouches. It's very important. We'll come to it in the next slide. And also, it's called indication has ectropion, lower eyelid retraction, and about the actually tear trough or significant orbital groove, irregular groove. This is controversy actually. I usually do augmentation fat transfer, so it's not really a contraindication for me. It's maybe a contraindication for others, but for me, the significant orbital groove is not contraindication. We do fat transfer, as you will see in our second video in this presentation. Please do not confuse eye bags with festoons and malar bags. This is a very common mistake. And always, many patients, they come to me after they have really the wrong operation. Many patients with festoons and malar bags, some surgeon mistaken, confused with lower eyelid bags, with puffiness, and do transconjunctival approach, and the patient benefit nothing from this procedure. So festoons and saggy, baggy, swelling below the eyes, primarily over the cheek on this area. I'm coming for next slide. This area usually, not above here. The eye bags actually in the lower eyelid, exactly in the lower eyelid. One finger below is the malar pouches and the malar bags. So do not confuse between the eye bags there, the lower eyelid bags, and the malar bags. And this is actually a combination of skin laxity and muscle weakening. creating a space that allows a collection of fluid, fat, and connective tissue. So the malar bags, and the festoons are always, it's pouches of fluid, fat, and connective tissue. So, for example, if you look at this patient on the right side, this is really there. This is an eye bag. It's inside the lower eyelid. So the fullness exactly inside the lower eyelids. While in this patient, if you look in the lower eyelids there is nothing. There is nothing there. There is nothing there at all. All the fullness where it's just below. The fullness is there. So that's really the festoon. This is the malar bag there. So in the lower eyelid there is nothing there. So the fullness is just below. Not the same like this one when you have the fullness in the lower eyelid. So here's the fullness in the lower eyelid. While the fullness there is below the lower eyelid. This is the lower eyelid there. And the fullness is below there. This is called the festoon or the malar bag. So do not confuse these between the eye bags and the malar bags. Again, in this patient, you see this is fullness there, very clear. This is an eye bag. This fullness is exactly in the lower eyelid. The fullness is exactly in the lower eyelid. While in the left side, you see the fullness is below there. That's where is the fullness here. It's the malar bag, malar pouch, malar mounds. That's the festoon. That's the festoon. While in the lower eyelid there is nothing there. There is nothing there. There is nothing there. You see? So please don't confuse between the lower eye bag there and the festoon there, because festoon, there is no surgery indicated in the festoon, and surgery really is hardly going to help you when you have festoons. Mainly treated by laser and by radio frequency deep microneedling. This patient, actually, by chance, she came to me last week. She's quite young patient, very beautiful patient. And you see, and she came to me, she said she has an eye bags, and she has visited many doctors, and she wants to have my opinion. And most doctor told her that they are going to do a blepharoplasty and many an external approach. So really, if you look at her lower eyelid there, it's quite free. There's nothing there at all. Nothing there at all. Why all the problem is there in this area, she got this fullness here, the festoon, the malar pouch. And you see, imagine, with this very young patient, if you are going with, and also that you got this such darker skin, if you are going to do a blepharoplasty, open approach, and your incision here, and it's really going to leave an ugly scar, very ugly scar with this type of skin color, skin type 4 or 5, plus that, the malar pouch is not going to benefit at all from surgery. It will come back again. So, the main treatment for festoons and malar bags are usually full face. We do usually full face erbium laser, and also the second one is radio frequency microneedling, penetrate the deep microneedling into the pouch. So our treatment is going to the subdermal area, mainly we are direct our treatment with the festoons and the malar pouch to the subdermal area, to the deep area, because where is the fluid collection and where is the fat collection and the connective tissue. So this is the best treatment, is the radio frequency deep microneedling plus an erbium laser, which can be done. If you do it twice, usually it helps the patient for quite a long time. It may help the patient for about 5 years ahead. So now we go back to our main subject, transconjunctival blepharoplasty, after we have given this nice theory introduction, and mainly to avoid confusion between lower eye bags and lower eyelid eye bags and the festoons or the malar pouches and the malar bags. Okay. Now, this is our first patient, really typical patient, very young patient with lower eyelid fullness. As you see, lower eyelid fullness. There is no tear trough, as you see. A typical case, younger patient, around 28 years old. As you see, we try to protect the cornea. Okay. See, was there on the eye. And when we start our incision, you see towards the. I'm using the, as you see, the Indiag laser, and mainly when you start your incision is directed towards the teeth. It's not directed down. It's directed to an horizontal, almost horizontal metal towards the teeth, and you open the conjunctiva exactly as if you are opening an envelope. It's very important. And now with sharp scissors, you see I open slightly and towards the medial, to the orbital floor medially. And you see, because I'm in the right plane, the fat start to pop out straight away because I'm exactly in the right plane. That's very important. So when you anatomy, you are in the right plane, and you see how the fat is popping out straight away. This is the medial fat. The medial band of fat. Most patients have a medial band and a middle band and a lateral band. And you should never try to remove any fat until you first identify the inferior oblique muscle. So identification of the inferior oblique muscle is a very important and an ABC. This is now the inferior oblique muscle, this pinkish structure there. So that's why now we're moving the medial band, which is medial to the inferior oblique muscle. So you should not remove any fat until you identify first the inferior oblique muscle, because in some cases it can be superficial, very superficial, and within the fat. Always remove 50% of the fat. Don't remove the full fat. Try to remove 50% of the fat in order to obtain later a very natural looking lower eyelid. And avoid hollowing and hollow shape eyelid after the surgery. So we excise 50% of the fat medial to the inferior oblique muscle, as you see, and then we cauterize it with the laser again. We use a laser to cauterize this, just to reduce the possibility of bleeding as much as possible, as you see. And then now, after we do so, we look at the muscle and we go just lateral to the muscle to identify the middle band. So we have medial band medial to the muscle, middle band lateral to the muscle. Okay, I'm just now lateral to the muscle. And again, using the blunt scissor now, going down to the orbital floor, looking for the middle portion of the fat. And that's it now. You see, I open the capsule, and the fat start to protrude now nicely once you open the capsule of the fat. You see now. So again, the muscle there, lateral, see the muscle there, lateral to the fat, now the muscle. So first the muscle was medial to the fat, now the muscle is in the middle portion, is lateral to the fat. So the muscle in the medial portion was lateral to the fat, now the muscle is medial to the fat because you are in the middle portion. And again, we remove 50% of the fat from the middle portion. I see the muscle very clearly there. And we stay lateral to the muscle. And very gently, we just get this fat very gently, as you see. And again, we use a mosquito. We try to remove around 50% of this fat. Still some fat down. See, very gently trying to dissect. And once you are on the right plane, so you are not messing around, as you see. And they will clip the fat. And again, with the laser, we cauterize the fat and remove this excess of fat from there. See, very nice, very clean approach. As you see, no scarring, transconjunctival approach. It will save a lot of problem of the open approach, like the ectopium. You know, the most common complication of open blepharoplasty or external blepharoplasty is the incisions, the cut, and the ectopium. Many patients will complain of retraction of the lower eyelid. So some excess fat medially, I'm removing again because it starts to bobbing out. Moving it again before I move to the lateral portion of the fat. So we have medial portion, and now after we do this, we move to the lateral portion now. So the use of the laser give you really very nice clean field, and also, controls the bleeding. You see now I'm going to laterally now, lateral to the lateral portion, part of the orbital floor, and getting this lateral band of fat. So this is now the lateral band. So we have usually three bands of fat: medial, middle, and lateral. You see, medial, middle, and lateral band of fat. As you see now, getting this fat from the lateral portion. And again, excise half of the fat and remove this half of the fat, and then cauterizing it. And again, we'll be doing the same on the other side. We'll be doing the same. Have you on the other side? No, okay. Okay, good. So very nice, very clean, very clean. Remove 50% of the fat to avoid the problem. The main advantage of this transconjunctival approach and open approach is scarring. No scar, that's very important, no scar, especially when you work on non-Caucasian patient. I mean, when you do, upper blepharoplasty, usually the scar is hidden inside the eyelid. But why in the lower blepharoplasty, the scar is very obvious, especially in young patients. They don't have any fold or skin creases. So it may leave really very ugly scarring. It's not only about the ectopium. It's only about even a very ugly scar in patients with skin type 4, 5, and 6. So this is really main advantage of the transconjunctival approach. And now the new trend also for many surgeons in the world, even with old patients 50, 60, they are doing actually, they are avoiding the open approach, the external blepharoplasty. They are doing transconjunctival approach, and then plus laser resurfacing at the end of the procedure, erbium fracture laser resurfacing. So now we just put edge to edge nicely, as you see. No sutures, edge to edge nicely. Very nice, edge to edge, as you see. And we put some antibiotic ointment. Usually this cut will heal within 2-3 days. If you look at the patient after 2-3 days, you will not find the cut. The conjunctiva will heal very nicely over a few days, as you see. So all the fat has been 50% of the fat removed, and then we'll be doing the other side. We are going to bypass. This is the end of the procedure. We remove the fat from the lower eyelid, as you see, without any cut, any incision. Also remove the fat from the corners of the upper eyelid by doing a stab incision deep there, stab incision in this area, deep 1 centimeter stab incision to remove the fat only from the corner of the upper eyelid. As you see, there is no incision, no cut there, because the patient has got no excess skin. So when patient has got no excess skin, you don't have to do full upper blepharoplasty. You can do only a stab incision in the above the medial canthus, 1 centimeter stab incision, and go straight and down and medially to the medial wall of the orbit, and excise the fat if you are working on the right plane, as you see there. And this really incision or cut, believe me, after 5 days you will not see. Next slide, please. So you see the great difference between before the fullness there, and really after. Very nice, very clear, very clean. After that, as you see, extremely nice result. Again, for the side view, you see the great difference between before and after. Extremely nice result. And also, if you look at the corners there, you cannot find really any sign of any scarring in this area. We remove the excess fat from the corner of the eye. This excess fat from the corner of the was removed during surgery. By small stab incision. Small stab incision in this area. Okay, next. Now, patients who have really an obvious tear trough, obvious groove, nasogenital groove, then during the blepharoplasty, we have to remove some of the fat, of course, but then at the same time, we do fat transfer, as you will see in this case. So in this now coming video, I want to concentrate mainly on the fat transposition to the tear raphe. As you see, the patient has got a deep tear raphe there, deep tear raphe. So also we are going to do a blepharoplasty, upper and lower transconjunctival blepharoplasty, but this is not enough to augment this or to this tear raphe. So we need to consider fat transposition. So we will remove half of the fat of the medial fat and half of the middle fat, and then get it
transposition this fat with suture, bring it from there to there. So we move this fat from this point to this point to augment the tearography. So we'll be moving the fat from there to augment the tearography and give the patient a more natural looking and fresh eyes. As you will see with the post-operative photograph of this patient. I hope you enjoy the video. Thank you.
So I bypassed in this video now the transconjunctival approach will be done. We have removed 50% of the fat from the medial bad, middle bad, and lateral bad.
I go with my marking now, and give a small dose at the end. Give me the factor again.
I already actually elevated removed the fat from the medial portion, middle and lateral 50%, and then transferring this fat. I also remove the periosteum over the orbital rim. The periosteum removed for about 2 to 3 millimeters below the orbital rim, and doing now this fat transfer, as you see, through the skin, then to the fat, and then back putting this fat to the nasojugular groove, to the tear trough, as you see.
Yeah. Section, can you do section? No problem. Okay. Washing with the muscle and above the muscle. Again, now here.
So transferring the fat.
Yes, I just keep washing the muscle, go back
into the groove.
The muscle is intact.
You have to make sure that the inferior oblique muscle is intact. You are away from the muscle.
Action of the center that we augment the tear trough, this area.
So keep looking at the inferior oblique muscle all the time. Make sure you don't catch it with your suture.
Okay. Keep it long. Okay. So go back again.
So we have done the medial portion. Now we do the middle portion again of this fat transfer. Again, the same through the skin. Just pass our needle.
The same. This is the muscle. You see the muscle is stay intact. There's some our muscle there. We go to the medial portion now. Okay, give me the needle again.
إذا هل الدكتور كان catch the needle.
Catch the needle.
Catch me needle.
It's tricky procedure. We have to keep washing for the muscle. Okay, with the tractor again. Before you do your suture, you make sure that you are above the muscle. We hold the medial fat. This is the medial fat. Hold for 1 second. Give me the scooter. I see the muscle. So I've been seeing the muscle now, the muscle. So I hold the medial fat. This is the medial fat. Okay.
This is the middle fat. So we're going now through the middle band of fat. We went first through the medial one. I'm going now through the middle fat, which is lateral to the inferior oblique muscle. We went through the skin. As you see, the titles are very clear. So we went 2 millimeters below the sulcus, below the groove, and then through the skin, through the fat, and back to the skin now, pulling up. It's called pull-up suture, pulling up the fat towards the groove. You see, it pulled up the fat towards the groove. As I said, you have to be careful. You keep watching the inferior oblique muscle, and make sure you don't catch the inferior oblique muscle with your suture to avoid any double vision or any visual issue with the patient after surgery. We're almost actually done.
So we did transposition the medial and middle portion of the fat to the tear trough line.
Transconjunctival lower eyelid with fat repositioning, the reposition of the fat to the tear trough groove. You see, this is a patient, similar patient with all this fat removed, as you see there, plus this deep tear trough there being nicely augmented and not obvious. This deep tear trough has been nicely augmented in this area. So it's really a very good procedure, no scarring, as you see, and the great results. Patient feel much more younger, much more fresher. Again, side view, you see all this fat pad being nicely removed, and the tear trough there also has completely disappeared, as you see, following the fat transfer. Okay, again, the same patient. You see the great difference between before and after in both the fullness and the tear trough. The great improvement. Okay. You see now the great improvement, all this fat removed, and the tear trough there has been completely disappeared as well. Okay. No, patient about to confuse again between. You jump. Again, before we finish, don't confuse eye bags with festoons and malar bags, please. We explained at the beginning of the video about this in full and details, and we put full photograph and illustration about the malar bags and the eye bags. So don't confuse in diagnosis between the eye bags and the malar bags. Examine the patient thoroughly, make your correct examination, correct judgment, and put the new surgical plan. There is no surgery for malar bags. It's only laser and radio frequency deep microneedling. While in the eye bag, you need to consider surgery and for the mainly the transconjunctival approach. Again, back again. So again, this is the eye bags. You see, and this is the festoons, the malar bags. So the malar bags are usually below, and this, you see the lower eyelid here is free. There is nothing there. So again, don't confuse between the eye bags and the malar is the eye bags there, and this malar bags down below. Don't confuse between the two. Okay, so if you have any question, please put your question. Again, take this QR. This will take you for over 1,000 operative video on rhinoplasty, blepharoplasty, face and neck lifting, and otoplasty. To our textbook free access on rhinoplasty, facial plastic surgery, 500 pages, over 1,000 illustration. To our previous webinars. This is Bashar Bizrah. Put your question and answer if you have. And we will welcome you, inshallah, for our next webinar. I hope it was useful, and that I have got to the point. And as I say, this is the most advanced technique on blepharoplasty transconjunctival approach. Also, I mean, I've been doing it for the last 29 years, but not many surgeons are doing it around. And as I said, the new trend now, even in America now, is to do it for older patients, to avoid the open approach, to avoid the external blepharoplasty, to avoid the scars and the ectopion. And they do it now in older patients, transconjunctival approach, plus erbium fractional laser or CO2 fractional laser after surgery to shred the skin and reduce the fine folds. Okay, I hope you have enjoyed. Thank you very much. Please give me any question. We have 2 questions. I'm waiting for the question to come to answer the question for you. And this is webinar number 26. Inshallah, our next webinar will be number 27. We'll choose a subject, nice subject, and we will send you. And I hope you have found it useful today. We are trying to not to take so long, maybe less than 1 hour, in order to avoid you become bored. Dr. Malo, can you hear me?
Yes, clearly, Dr. Bashar.
Any question, anything? Well, I'm waiting for the question.
No, I mean, thanks very, very much. And this was just a great presentation and incredible results. And you were absolutely right, pointing out that there is a lot of difference between fatty bags and malar fat bags and festules. So, you know, we need just to be careful in not confusing one with each other. And so just pick the right patients for the transconjunctival blepharoplasty. Thank you.
Okay, I have 2 questions. The first one, when do you prefer transconjunctival approach? We just actually, I think we answered this question during the presentation. We said in younger patients, when they don't have much fold, no much redundant skin, no much excess skin, no much ptosis of the skin or eyelid, then transconjunctival is the procedure of choice. Even now, I just said in older patients, even patients have got skin laxities, are trying to avoid the open approach because of the scarring, especially in non-Caucasian patients, and even in Caucasian patients, the ectorbion, because once you cut through the muscle there, when the muscle during the healing process of the muscle, wound contraction of the muscle, wound scarring, when in the majority of patients is going to cause ectorbion. So now the new trend, even for older patients, is to go for a transconjunctival approach and either excess of the excess skin only without the muscle, or transconjunctival approach with fractional laser, either CO2 laser or the most advanced, the erbium laser. Second, the question: how long do you keep those sutures for? Usually about 1 week, 7 to 10 days actually. Not more than 10 days, definitely. Okay, so another question. What you're setting for, it's YAG laser. Yes, it's erbium YAG in the YAG laser we use. And what suture do you use? The suture we mean for the conjunctiva, we do not do any suture, as you said. No suturing. But for the fat, you can use either Vicryl, or you can use Prolene if you want 60 or 560 Prolene. This is the best thing to use. Or you can use monocrete, but you need suture to easy to remove. So either you can use the Prolene 60 or use Vicryl. Any more questions? How to identify patient for transposition of tear trough? If you have a tear trough, if you have an obvious nasojugular fold, if you have an obvious orbital nasal fold, so when you have this tear trough, deep tear trough, obvious tear trough, this is then the right patient to do the fat transposition. So I say, the first case, the first video you have seen, there was no tear trough, there was no groove, no nasojugular groove. But the second patient you have seen, there was an eye bag plus a deep tear trough. So that's all the question. I hope you have really enjoyed, and thank you very much for staying with us today, and see you inshallah in the near future, maybe next month, for our next webinar. Thank you very much. This is Bashar Bizrah for Rhinoplasty Bizrah Academy and the Academy of Facial Plastic Surgery. Thank you very much.
Thank you.
Thank you, Professor Marlo.
Thank you, Dr. Bizrah. Thank you.
Thank you.